listening to the Pharmacy Podcast Network.
Hello, and welcome to PTCE's Pharmacy Connect, a podcast focused on continuing education created by pharmacists for pharmacists. PTCE is the leader in pharmacy and managed care education. In these episodes, listeners will be presented with the most recent clinical updates and strategies for implementing into practice. And now, here's our host and founder of the Pharmacy Podcast Network, Todd Urey.
PTCE Pharmacy Connect listeners, welcome back to another episode of PTCE Pharmacy Connect. We're going to be digging a little deeper into some information that we've talked with before and welcoming back two of our stars of the PTCE Pharmacy Connect family. I'd like to welcome back Dr. Laura Bobolts. Welcome back to PTCE Pharmacy Connect. Laura, how are you?
Wonderful. Thank you so much for having me.
And the one and only Dr. Victoria Nachar. Welcome back to PTCE Pharmacy Connect.
Oh, thank you. I'm so honored to be back.
I'm turning this over to Laura. Laura, you're going to lead us in today's conversation and really digging deeper into the conversation around emerging treatment landscapes of relapsed refractory diffuse large B-cell lymphoma. Take it away, Laura. Thank you so much for being here.
You got it. Thank you so much, Todd, for the very kind introduction. And when you think about treatments for relapsed refractory diffuse large B-cell, oh my gosh, my head just wants to spin, right? Because there are so many new therapies. We have CAR T-cell therapies today, antibody drug conjugates, monoclonal antibodies. And wait, it doesn't stop there. There's even more drugs coming down the pipeline. So there's multiple T-cell engaging bispecific antibodies under investigation today. So with all of these novel therapies that are current and emerging, I'm really happy to have this opportunity to talk with Dr. Nachar about how do you optimize these therapies for our cancer patients. So really, I'd love to ask Dr. Nachar, are there differences in the patient populations in the clinical trials? So thinking about the L-MIND, LOTUS-2, polatuzumab vedotin, and BR versus BR for these novel agents in relapsed refractory setting for treatment selection?
Yeah, that is the million-dollar question. That's a great question, Laura. There were differences in the patient populations in these studies at baseline. And unfortunately right now, we don't have head-to-head comparator data for these agents, right? So when we're trying to choose, what might be the best for our patients, well, it's really exciting to have all these options. It can make your head explode, trying to figure out what is the best. And so often we look to, who were the patients included in these studies and how does it apply to the patient that we're seeing in front of us? And so I think some things that come to mind for these novel agents when thinking about these patients were, in the tafasitamab lenalidomide study, these were patients who had only received 1 to 3 prior lines of therapy, and they were transplant eligible patients. The median age was about 72, and primary reasons for transplant eligibility was age. Now, I don't know about, your center, my center, we could debate, but, if you have a fit patient with a performance status of 0 to 1 who's 70 or younger, it's kind of confusing why age was a reason for transplant eligibility in the trial. Nonetheless, these were, not heavily pretreated, a little bit older population. They had never received prior CAR T-cell therapy. So tafasitamab also targeting CD19, like our CAR T-cell products. No one in this study had prior CAR T-cell therapy. And I want to mention that, it did take about 2 months to see a response. So thinking about that, when we think about tafasitamab lenalidomide, maybe it's not something that works quickly, but maybe it's a great option for a patient in the second line who's not a candidate for autologous stem cell transplant or CAR T-cell therapy. In the polatuzumab vedotin study, again, primarily transplant eligible, but these are fit patients, right? They enroll in a clinical trial. And the reasons for transplant eligibility, again, age and comorbidities. It doesn't really make sense, who these patients are. And I will say, this was a randomized phase 2 study, primary endpoint response rate, but there was a secondary endpoint of overall survival, in which overall survival was significantly better, but this was not the primary endpoint of the study. And it probably was super underpowered power to say that there was a difference. And so, patients in the PBR study had like 2 or more lines of therapy, so more heavily pretreated patients. Again, no prior CAR T-cell therapy. And then loncastuximab was, I would say, like a completely different patient population. They were 3 or more prior lines of therapy. There was a small percentage of patients who had received CAR T or who went to CAR T after receiving loncastuximab. They also, in the loncastuximab trial, the LOTUS-2 included patients with very aggressive high-risk DLBCL, those with double hit and triple hit lymphoma. And so, I think that these are really important to really tease out these characteristics, right? Because we've got a patient in front of us. We want to think about what is the best. And so there's totally differences in these patients. And again, I think when you take that into consideration, you can't say based on the outcomes, one is better than the other.
That's always the toughest thing in our world of oncology pharmacy, right? How do you pick and how do you decide if one therapy is better than another? So I really love how you could tease out the data from the clinical trials with their enrollment and then apply it to patients in your clinic. That age might not be the deciding factor, that line in the sand. So I really appreciate that vast knowledge that you have there. But it makes me wonder now, everyone's thinking about the CAR T-cell therapies, right? And when I was looking at this, it was scratching my head because I saw that only 2 out of the 3 CAR T-cell therapies in diffuse large B-cell lymphoma that's relapsed refractory had an event-free survival improvement in the second-line setting. That was Axicell in the ZUMA-7 trial and Lysocell in the Transform trial, but granted not FDA approved right now, but Tisacell actually did not improve event-free survival in the Belinda trial. Now, why do you think that might be? Because some might say, hey, these are amazing novel gene therapies. Shouldn't they all have great striking efficacy over standard of care? So why were possibly 2 therapies beneficial and one, not as beneficial in the second line setting?
That's a huge head scratcher. And I don't think we know for sure, right? So they were, ZUMA-7, Transform, and Belinda were all very similar prospective randomized phase 3 trials in which, their respective CAR T-cell product was compared to standard of care, which is salvage chemotherapy, and then an autologous stem cell transplant for patients who demonstrated sensitivity to chemotherapy. Now, at baseline, these were high-risk patients. So these were patients who were either refractory to first-line chemotherapy or who progressed early within the first 12 months. And like you said, Axicell and Lysocell both had an improvement in event-free survival and gained FDA approval for the second-line setting, whereas Tisacell did not. I think there are, though, some differences in these studies that may explain why Tisacell failed in the second line. All of these studies had a different definition of what event-free survival was. And I think you could also nitpick if event-free survival was the right endpoint for these studies. Even progression-free survival may have been better. Ultimately, we want to see overall survival, right? But in some of these studies, a stable disease was considered an event, and the time point at which they were assessing for stable disease was very different. And we know that Tisacell is one of the CAR T products that takes a little bit longer to work. And this is from the studies that were done in the third line settings. And so, they were calling stable disease an event very early on. And so you wonder if they had waited longer, would the EFS have been the same? Something that comes up all the time, right, with CAR T-cell therapy is getting a patient to CAR T-cell therapy. There's so much that goes into pheresing and modifying the cells and getting them back. It can take days on end. Many patients with relapsed refractory DLBCL cannot wait that long, right? They can't wait 52 days, like in the Tisacell study, to receive product. And oftentimes they need therapy before, and we call this bridging therapy. And so in the studies, there were differences in bridging therapy that was offered and how many patients received bridging therapy. In the Axicell study, they didn't the only bridging therapy that was allowed was corticosteroids. And corticosteroids can't hold many patients with relapsed refractory DLBCL. In the Tisacel study, so Belinda, 80% or more of patients had bridging therapy, and even a percentage of those patients had 2 different chemotherapy regimens as bridging. So very heavily pretreated patient population, and then a high amount of bridging therapy in the Lysocell study. So I think differences in who received bridging therapy could indicate that these were vastly different patient populations. And again, the time to therapy, I would say realistically at our center, it takes at least 4 to 6 weeks, right? If we've got everything in place, insurance authorization, we're getting those T cells, we're sending them off. In the Axicell study, it only took 14 days. And I don't really think that that's realistic and reflective of real world. So I think there are a lot of differences in these studies. And you could say, this may have been the reason why, Tisacell did not have the improvement in event-free survival like the other 2 CAR T-cell products. Ultimately, we don't know, but I think it's important, to note these differences and think about which population may have been more reflective of real world.
Absolutely, because these are real patients you're treating in the real world. And it does make it hard to apply those clinical trial results when the trials had endpoints defined differently, patient populations that were included that were so different, manufacturing processes that might not reflect the real world. Gosh, I don't know how you even do it. It makes my head spin. So
it's a lot, yeah.
It is so much, but I bet you really want to optimize CAR T-cell therapy, right? For patients that are eligible. So say for some reason, maybe the patient did not receive it in the second line setting. Are you looking to utilize CAR T-cell therapy then in the third line setting? Should they be fit for it? And if so, how do you pick in clinic amongst the 3 agents? Because there you have all 3 agents do have positive efficacy data, the ones that we talked about, Axicell, Lysocell, and Tisacell. So how do you choose?
Yeah, that's a really good point and a good question. For patients who maybe relapse later, so 2 years after first line therapy, the standard of care is still, give that patient salvage chemotherapy with a platinum-based regimen. If they demonstrate a response, so chemosensitive disease, they should go to an autologous stem cell transplant. We know that will cure a percentage of patients, but there's still going to be patients that relapse post-autologous stem cell transplant or who maybe just aren't candidates for an autologous stem cell transplant, but they still may be fit enough for CAR T-cell therapy or relapsing post-transplant. I think a perfect situation in which you may go to CAR T-cell therapy at that point. And like you said, we have all 3 products FDA approved in that situation. And that was really the first approval for the CD19 CAR T-cell products in DLBCL. I think a little bit has to do with slot availability. These products, we get slots from the manufacturer if you're an institution. And so, maybe it's not your preferred for whatever reason, but if you have a slot for it, you're going to take the slot. So a little bit of is just logistics. There are some differences in the toxicity profile, and it really comes down to differences in the co-stimulatory domain of the CAR T-cell product, whereas, the CD28 co-stimulatory domain of Axicell may cause those T cells to replicate faster. They don't persist as long. Maybe you see more cytokine release syndrome versus the 4-1BB co-stimulatory domain. Don't see as high of toxicity, but it's really speculative. And I would say, at least at our institution, you're going to take whatever slots available, to you to get that patient that product the fastest.
That's wild. And I'm just curious, so I have to ask, I heard one oncology pharmacist said they only get 1 slot per product per month. And if that, they're even lucky to get that. So what do you tend to see for slot availability at your center?
I think it depends on the product and like the malignancy as well. For DLBCL, I'd say we have more slots than that, but we kind of just, go with whatever is available. I would say we get several slots a month, but across all 3 products.
Yep. That's great to hear. Great for our patients as well. We need to be able to expand access to those therapies. And then let's switch gears and talk about the exciting new therapies potentially on the horizon, right? So we have several CD20 bispecific antibodies in the pipeline. You have epcoritamab, glofitamab, and I'm going to stop right there because I'm going to mess up the rest of the drug names. So if multiple of these CD20 bispecific antibodies are FDA approved in the coming future, what will be some potential considerations for therapy selection that pharmacists really need to know about?
It's such a good question. So many good questions today. It's going to depend upon, what happens with the FDA approval for these agents. Are they going to have a risk evaluation mitigation system, a REMS program? Probably, from what we've been seeing from other bispecific antibodies. But what the exact components of that REMS program are going to be are unknown, right, until they're approved. They may require a hospitalization or a brief hospitalization or suggest a hospitalization. And so I think, it'll depend upon each institution, what you're able to do, and then the differences in the recommendations for these products. And I think the recommendations are going to depend upon what fleshes out when it comes to the toxicity of these drugs. So the bispecific antibodies, just like CAR T-cell therapy, have those same immune effector cell associated toxicities, cytokine release syndrome, and neurotoxicity, or ICANS. Now, it's all cross-trial comparison. These are early trends, and I can't say definitively what we're going to see, but what we are at least seeing right now is that with the bispecific antibodies, the risk of CRS and neurotoxicity may be lower than with CAR T-cell therapy, and it looks to be less severe. The onset looks to be about the same, but the duration of CRS and maybe neurotoxicity seems to be less with the bispecific antibodies than CAR T-cell therapy. So I think knowing this and some of the mitigation strategies that are going into mitigating a lot of these cytokine release and neurotoxicity with the bispecific. So looking at ramp up dosing, starting at very low doses to try to mitigate that big cytokine burst. Pre-medications, they're looking at giving these subcutaneously. So we're not going to get bolus doses through IV, hopefully decrease peak cytokine levels. With some of that, I think we're going to be able to push these agents to be administered at centers where CAR T-cell therapy is not available. So community centers, smaller hospital or cancer centers across the country, which is great, right? Because we're improving access for patients who right now maybe don't have access to CAR T-cell therapy. Their frequency is also, going to be unique in that some of these are weekly, some are twice weekly, once monthly. Again, going to really depend upon the agent and what gets FDA approved. But I think just thinking about if and when multiple are approved in the same class, I'm thinking that each institution is going to have to take a look at all of these factors as long as there's no clear winner when it comes to efficacy or safety. And I don't think there's going to be, because there's going to be no head-to-head comparator of them. But I'm just throwing some ideas out there, right, for the future to think about. Should we pick a workhorse? Should we have a couple? Should we have all 5 of them, right? And have criteria for the patient. And so I think that's some other considerations when it comes to therapy selection for these bispecifics that'll occur that we're not used to thinking about.
I think it's really encouraging for patients to think that you might have all of those problems that are good problems to have amongst deciding with many therapies what to put on formulary and all the nuances, and then also how to expand access to care. Like you said, to potentially community hospitals. That would be fantastic for our patients. I would absolutely love that. But now talk to me a little bit about the toxicity, since you already went into the CAR and the bispecific antibodies. What about the toxicities of tafasitamab and lenalidomide, polatuzumab, loncastuximab? What do you see there?
Yeah, we tend to focus on the immune-based side effects, cytokine release and neurotoxicity. We don't see those toxicities with tafasitamab, polatuzumab, loncastuximab. So while these are novel immunotherapies or in the class of it, the toxicity profiles are actually vastly different. With tafasitamab, Alone, it's a monoclonal antibody, so it's pretty well tolerated. There's a small risk of an infusion-related reaction. But otherwise, a lot of the toxicity that we see with tafasitamab, I guess you could say, comes from the partner drug. So tafasitamab is approved to be given in combination with lenalidomide, and that's because they seem to have a little bit of synergistic activity, whereas tafasitamab alone did not have a good single-agent activity. We added lenalidomide. There's some immune stimulation happening there, and we see some durable responses with the combination. However, in the trial, the dose of lenalidomide was 25 milligrams. And in lymphoma, that is a really high dose. Most patients can't even tolerate 20 milligrams of lenalidomide in lymphoma. And so typically trials don't go above 20 milligrams, but here they gave 25. And so we see a lot of myelosuppression with the combination, rashes, increased thrombosis risk, particularly from your lenalidomide. So patients need to be on aspirin prophylaxis, most commonly aspirin, diarrhea. And a lot of this is attributed to the lenalidomide portion. And so in practice, if we're using this, there's a lot of starting at lower doses and increasing as tolerated, or starting at the higher dose of 20, 25. But often we have to back way down because patients just can't tolerate it, especially thinking the patients in that trial, median age 72, not CAR T or auto transplant candidates. When it comes to polatuzumab, because the payload is vedotin, which is a microtubule inhibitor, it causes peripheral neuropathy. And so we have to think about a patient's baseline peripheral neuropathy, because we know that R-CHOP causes peripheral neuropathy. They may be coming in with some baseline, as well as polatuzumab is approved to be given in combination with bendamustine and rituximab right now. Bendamustine definitely increases your infection risk. We need to be giving PJP prophylaxis for these patients. You see your infusion reactions with rituximab. And then, something to note that, has been talked about before, but bendamustine, extremely lymphodepleting. So if we're using it prior to collecting a patient's T cells for CAR T cell therapy, there's concern that bendamustine can negatively impact those T cells. So we want to hold that, before we collect the T cells for CAR T. And then loncastuximab is unique. It's an antibody drug conjugate like polatuzumab, but its payload, tesirine, is an alkylating agent, and so it causes cross-links in DNA. With loncastuximab, we see pleural effusions, peripheral edema, pericardial effusions. And so to mitigate this, the clinical trials implemented a steroid premedication. So it's dexamethasone twice a day, starting the day before the infusion, the day of, and the day after. And we see that the rate of peripheral edema, pericardial effusions, pleural effusions decreases significantly. So we need to make sure that patients are getting those steroid premedications. Now, the other thing with loncastuximab is it causes photosensitivity, which, as pharmacists, we're used to hearing about, or protect yourself from the sun. But with loncastuximab, it is very, very severe photosensitivity, severe rashes that occur most commonly in those sun-exposed areas, but that can occur despite being exposed to the sun as well. And this is to the point where the package insert manufacturer actually recommend patients protect their skin through glass. So like in the car window, right? Which we're not used to seeing that severe of skin toxicity from the sun. And so we're in Michigan, right? In Michigan in December, maybe this isn't, it's as big of a deal. We don't have lots of sun, but if you live in Florida or California, right, there, you have to really educate patients and counsel them on this. And it may be a quality of life issue. And so while they don't cause CRS or neurotoxicity, they have their own unique toxicity profiles, and they're very nuanced, and they definitely come into, those treatment decision-making.
That does sound nuanced. And yes, being a South Floridian, we like our convertibles or our sunroofs open. So holy moly, patients get accustomed to the sunscreen.
Yeah, no convertible on the loncastuximab.
Who would have thought, right? Now you have to rethink your car choice with the cancer drugs.
Oh, man.
That is so wild. So some of these agents may cost more than a car, or let's say multiple cars, or maybe even more than a shiny sports car or supercar. So I really have to go there because the financial toxicity of our cancer therapies is so real. If our patients can't afford the therapy, all these scientific advances that we have, all the great trial data you just spoke about, are really fruitless for our patients if they can't afford the therapy. Financial toxicity can put patients into bankruptcy, lead to poor outcomes, lower quality of life. They might have to borrow money from their family, might not be able to pay their bills. And just in this day and age, when everything seems to cost more, I just couldn't imagine what our patients have to go through right now. My heart goes out to them, truly does. So I've got to go there. Talk to me about how costly these novel therapies are for relapsed refractory diffuse large B-cell lymphoma.
So expensive. And it's hard, right, to put a dollar amount on benefit. And it's hard to put a dollar amount on, prolonged survival or how much is a month of survival worth. We know that in several analyses, the total cost of CAR T-cell therapy can exceed $1 million per person. And when we're talking about all these advances and, how great they are in improving access to care, with the cost of these therapies has potential, I think, to bankrupt the system. And so it's so hard because they're great and they can improve survival for our patients. And that's ultimately what we want. We don't want to put, financial strain on a patient to do this. And the cost is unique in that we're used to just thinking about what the drug costs, right? This pill costs $20,000 a month. My copay at the pharmacy for my blood pressure medication is $5 a month, right? But when it comes to these novel agents that are so complex logistically, with hospitalization requirements, with monitoring, with the amount of visits, with the supportive care, with the cost of managing these unique toxicities of CAR T and bispecifics like cytokine release syndrome and neurotoxicity, when you add all of those ancillary costs in, the cost is astronomical, right? Cost of an ICU admission, the cost of all the supportive care, infection prophylaxis medications, the cost of gas to get to your appointments and put them, the gas for your convertible to get to your appointment, right? There's so many costs that can't be factored in. And so, they're really expensive. And I think, well, the CAR T-cell therapy is a one and done in theory. Bispecifics are indefinitely. These aren't FDA approved yet, so we don't know costs and what that's going to look like. But I think some conversations are going to come down to an indefinite therapy and how costly it is versus, a one and done CAR T-cell therapy. Keeping in mind, though, that if you don't have access to one, then if that's the best therapy for you, we need to do what we can to mitigate the cost.
Absolutely. So much to consider, and especially with your car choice. Oh my gosh. So what about when these therapies move up to an earlier line of therapy, right? Like CAR T-cell therapy moved from third line or later to now second line or later, diffuse large B-cell lymphoma. What if these therapies move to frontline setting? Talk to me about how costs may change in that type of scenario.
Yeah, I think it's hard. And with the readout of the POLARIX study, which moved polatuzumab to the front line in combination with our CHP instead of our versus our CHOP, there's been some cost-effective analyses. And I think cost-effective analyses are hard to interpret because it really is extremely kind of subjective based on what data you put in and what you factor in. And you can find some studies that say that polatuzumab in the frontline may be cost-effective if it can prevent more relapses. So if we're curing more patients, then less patients need these more costly therapies in the relapse refractory setting. And so perhaps spending more upfront saves us more later. But I don't think we know that yet for sure. We need a long time follow-up to know that less patients are relapsing. But there are some cost-effective analyses that say that even if polatuzumab improves survival and less patients relapse, it is still not cost-effective. So I guess my answer is I don't know. I think we might it's hard to know if we're saving costs or shifting cost. And we could potentially be over-treating some patients, right? Some of these studies that are done in the front line, they include just large buckets of patients. Maybe there are patients that do, just fine with R-CHOP alone and are cured of their disease that don't need the additional expensive agent. So I think it's a little hard to figure out, who exactly is benefiting. Are we over-treating some patients and then in the long run, it's not going to be cost effective, or are we really actually saving cost in the relapse setting?
Wow, there's so many considerations there. But with all that being said, talk to me about any strategies to reduce costs for these novel therapies. Is there any hope to help our patients with that risk of financial toxicity?
I think there's opportunity, but we would have to get, very creative. And so I think a lot of this is going to come down to agents that we maybe have been administering on the inpatient setting or that maybe suggest a hospitalization. So thinking about those bispecific antibodies, can we shift those agents and the treatment of those patients into the outpatient setting? I think we all know, tale as old as time, any therapy giving outpatient, right, is the best way to do it from a cost perspective, then take up that hospital bed. However, if we're going to shift the cost outpatient and potentially save therapy, I think we need to be able to do it safely. And it's a big role for pharmacists to come up with policies, procedures, working groups for their institution to figure out how we're going to give these things outpatient and how we're going to monitor for the toxicities and even manage the toxicities outpatient. Grade 1 and grade 2 cytokine release syndrome can be safely administered. Can be safely managed outpatient. Many places are doing it, but I think it's very logistically complex. You need, a way for a patient to quickly call you and tell you something's going on. You need them to be able to get to you quickly. You need space to be able to manage them outpatient and maybe not even through the emergency department, right? You need an infusion center or some, intermediate level care to be able to give hydration and monitor them, maybe steroids, tocilizumab, and monitor them for a couple hours. And I don't know if places are well equipped and have the resources, right, to be able to do this. But I think if we can get creative and figure out how to shift and keep these people out of the patients out of the hospital, then I think, those are some strategies that are being examined to reduce the total cost of care.
Absolutely. I can really respect that. I hope that we do see more outpatient administration of these therapies, especially CAR T-cell therapy going forward as people get more comfortable with it.
Yeah. And I will say that, the bispecific antibodies, a lot of those clinical trials early on were doing a little bit more hospitalization than maybe they'll even get labeled for if and when FDA approved. But there are studies ongoing for many of them. And there's some updates at the American Society of Hematology conference next weekend, looking at even full administration of those agents outpatient. They're very early studies right now. So, I think manufacturers are also looking at how do we set up these community centers and other institutions for success when it comes to outpatient administration.
I love it. And I could pick your brain all night long, Dr. Nachar, because you really have such a great grasp of the data and the knowledge in this area. But final question, if you're ready, what would you really say?
Bring it on.
You got this. What would you say is the single most important takeaway for our pharmacists listening in today about all of these novel immunotherapies being used in relapsed refractory diffuse large B-cell lymphoma?
Single most important, takeaway? That's a loaded question. Maybe I have a run-on sentence, but I guess I would say that, there are many novel immunotherapies, CAR T-cell therapies, antibody drug conjugates, monoclonal antibodies, and then the bispecifics, are not far away in relapsed refractory DLBCL that are really improving outcomes for patients. But I think there are many questions remaining when it comes to choice of therapy, optimal sequencing, and in the absence of any slam dunk data telling us how to choose among these agents. I think a lot of variables come into play: safety, efficacy, logistics. excitingly, these bispecific antibodies under investigation, I think, have opportunity to provide additional therapy options for patients, but also improve access to care for patients, which I think is an important takeaway point for the listeners.
Absolutely. I love it. Thank you so much, Dr. Nachar. You are brilliant, and it has been truly an honor to speak with you tonight.
Thank you so much. I had a great time.
Lara and Victoria, thank you so much for this information. This has been an absolute joy to be listening to Pharmacist Educating Pharmacists. And with that, we cannot wait to the next PTCE Pharmacy Connect. Thank you so much. Have a great day.
Thanks for tuning in to the PTCE Pharmacy Connect podcast. Your feedback is important to us. Please share with us your thoughts on this episode and other topics you'd like to learn about. Go to pharmacytimes.org/contact and send us a message.